Good morning. My name is Dr. Susan Wolver, and I'm a general internist practicing primary care and obesity medicine at Virginia Commonwealth University in Richmond, speaking on my own behalf. Thank you for allowing me the opportunity to speak, and thank you for your commitment to improving the health of our nation. I am here to implore you to consider the mounting evidence in support of a low-carbohydrate diet as a viable and necessary approach in the new dietary guidelines. I've been practicing medicine for 30 years. The first 24 were a cycle of seeing patients with their uncontrolled chronic conditions, tweaking medications while watching them gain weight and their diseases worsen. That was in spite of my continually recommending exercise and a diet of whole grains, fruits, vegetables, lean meats, and low-fat dairy. But it never worked, and I mean never. In those 24 years, 2 people lost weight and 1 gained it back. And then, when I got to be middle-aged and that same advice no longer worked for me, I realized that my advice might be wrong. I tried a low-carb ketogenic diet, lost weight effortlessly, and tried it with my patients who were desperate for help. Patients like a young woman with newly diagnosed out-of-control diabetes. She ate perfectly according to the guidelines, and standard advice would have been to eat less, move more, and start insulin. She would have been relegated to a lifetime of needles, weight gain, and the psychological impact of living with a chronic disease. Instead, I taught her a low-carb diet, and in just 3 months, she was barely in the pre-diabetic range, lost 25 pounds, and was overjoyed. More than 90% of the patients who come to me on insulin are able to discontinue it. In April, the American Diabetes Association said, and I quote, "Reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia." But a low-carb diet is beneficial not just for patients with established disease. A recent study by the University of North Carolina showed that a full 88% of the nation has at least one of the 5 components of the metabolic syndrome. Results from my patients and studies like the A to Z trial prove that a low-carbohydrate diet not only has better weight loss than standard dietary advice, but better improvement in every component of the metabolic syndrome. Nearly 1,500 people have come through my weight loss clinic over the past 6 years with an average weight loss of 12% at 9 months and have kept it off for at least 18 months, with a reduction in medication burden, improvement in blood pressure, fatty liver disease, sleep apnea, arthritis, and enhancement in quality of life. I was so burned out from doing the same thing over and over and not getting results. I am now excited about practicing medicine again, knowing I can help my patients improve their health. But we are tired of having to defend a low-carbohydrate diet as a valid dietary choice. It is working for us, is supported by irrefutable medical evidence, and demands a place in the guidelines. Thank you.
Chapter 13. Good morning to everyone in the committee, and thank you for this opportunity to speak. I'm Dr. Priyanka Wali. I'm a practicing physician from California who specializes in obesity medicine. I have treated thousands of patients who suffer from obesity and obesity-related complications such as diabetes and metabolic syndrome. I work on the front lines, and I use nutritional plans as a therapeutic tool for my practice every day. I'm here because I'm very concerned that the current nutritional guidelines do not reflect the current health status of our nation. You know, if laughter was the best medicine, then the nutritional guidelines are best practice because they're a joke that's fallen flat. And I believe that's because the committee has forgotten the #1 rule when it comes to joke writing: know your audience. Well, let me tell you about your audience. 1 in 5 Americans has diabetes. 1 in 3 has pre-diabetes. This is a disease that will kill you slowly by eating away at your brain, your vision, your vital organs. We suspect that 50% of Americans right now have pre-diabetes. They just don't even know it. These are diseases caused by high insulin levels, which is caused by eating carbohydrates. And it doesn't matter if it comes from whole grain or cane sugar or 100% fruit juice. A carb is a carb is a carb. If you have pre-diabetes or diabetes, you are essentially carbohydrate intolerant, meaning when you put carbs in your body, it becomes affecting your hormones, you become hormonally imbalanced, and you become sick. These are the medical facts. The current guidelines advise that consuming no more than 10% of calories from excess sugar. How can we make this recommendation if we know that half the country is carbohydrate intolerant? It's like if you knew someone had a life-threatening food allergen, you wouldn't tell them, well, avoid the food allergen, but you can eat up to 10% of your calories of that allergen. You would tell them, no, avoid this allergen at all costs. So why would it be any different with sugar? If there are people in this country who are carbohydrate intolerant, and that's half the country, please change the excess sugar limit recommendation from 10% to 0%. Please reduce the recommended carbohydrate intake by half to reflect the current health status of our nation. The guidelines are a joke now, but they don't have to be. The guidelines should be medicine because food is medicine. I've seen it in my practice with my patients, and right now we are prescribing the wrong medicine for our country. Thank you.
Hello, my name is Dr. Sarah Hallberg, and I work for Indiana University Health and Verta Health, and I am pleased to be here today. I have worked in the obesity field for almost 25 years. I want to start out with a really critical issue that was discussed yesterday, which is that a low carbohydrate diet may potentially be defined as less than 45% of calories from carbohydrates. Let me be very clear. As one of the foremost experts in this field, that is not a low carbohydrate diet. The scientific literature strongly suggests that there are no advantage to that degree of carbohydrate restriction in either keeping people well or restoring health. A low carbohydrate diet is under 30% of calories from carbohydrates, and the best results in metabolic disease and obesity is with a very low carbohydrate intake, which is under 50 grams of carbohydrates a day or around 10% of calories. I worked for years as an internal medicine physician in primary care, and I instructed my patients to follow the dietary guidelines. My patients brought back their food records, talked of their new exercise programs, and got sicker and more obese. I got more despondent as a provider. I was not helping them at all. Then I spent a year scouring the scientific literature on how I was going to solve the unsolvable problem. I discovered a low-carb eating pattern, and the hardest thing for me to do was make peace with the fact that despite my best intentions, I had previously been making my patients worse, not better, with my advice. I founded the obesity program at Indiana University Health Arnett as a low-carbohydrate program almost a decade ago. The results we saw were almost unbelievable. People losing weight, regaining their health, reversing hypertension, fatty liver disease, lipid disorders, and type 2 diabetes. I am now the PI on the largest and longest controlled clinical trial ever to look at very low carbohydrate nutrition interventions for type 2 diabetes, and here are our results. At 1 year, 60% of the 262 intervention patients had reversed their diagnosis of type 2 diabetes. At 2 years, this number remained at 54%, and our patients had lost an average of 12% of their body weight, an average of 30 pounds, while improving their 10-year cardiovascular risk score. Let me repeat, 54% of patients with a diagnosis of type 2 diabetes had reversed out of this disease. Compare this with the Women's Health Initiative, which tested the dietary guidelines and found that they did nothing to prevent diabetes or cardiovascular disease risk reduction and resulted in less than 5 pounds of weight loss at a year. I think it is very important to review the enormous body of clinical trial evidence for a low carbohydrate eating pattern in obesity and early metabolic disease. Did you know that a very low carbohydrate eating pattern does not change plasma saturated fat, yet a high carbohydrate diet increases it? This is one of a number of studies that cannot be ignored.
Commenter.
Good morning. My name is Dr. Georgia Eade. I'm a psychiatrist practicing in Massachusetts. Thank you all for your time and expertise to these important questions, for dedicating your time. I'm here because I share your conviction that a healthy body and mind begin first and foremost with a healthy diet. It doesn't make sense to me that 1 in 6 Americans should need psychiatric medication. I specialize in nutritional psychiatry so that I can focus on addressing root causes of mental illness rather than simply controlling symptoms with drugs. Most neuropsychiatric conditions share many root cause mechanisms: nutrient deficiencies, inflammation and oxidation, imbalances in hormone and neurotransmitters driven by unstable blood sugar and insulin levels, and cerebral glucose hypometabolism that sluggish brain glucose processing, strongly correlated with insulin resistance and a key feature of Alzheimer's, now often referred to as type 3 diabetes. My strategy for optimizing brain health is straightforward. I focus on getting people to eat foods that best deliver essential nutrients to the brain and exclude foods that place the brain at risk. I'd love to point them proudly to our guidelines, but how can I do that when our guidelines explicitly recommend refined grains, refined carbohydrates, powerful promoters of inflammation, oxidation, and insulin resistance, all root causes of brain dysfunction? When our guidelines explicitly recommend industrially produced seed oils, which tilt our systems too far towards inflammation? When our guidelines explicitly warn against the consumption of red meat, grounded almost exclusively in epidemiologically based hypotheses about potential health risks that aren't supported by anthropology, physiology, or human clinical trials. The science is clear that including animal foods is the most reliable way to obtain most micronutrients in their most bioavailable form, including some which are difficult or even impossible to obtain from plant foods. When our guidelines recommend we base our diets on grains and legumes, starchy staples which are low in nutrients and less fortified, high in anti-nutrients, and too high in carbohydrate to be safe for the growing majority of us with insulin resistance. So instead, I recommend a whole foods pre-agricultural diet as a starting point, or in cases of compromised brain glucose metabolism, a ketogenic diet. These work very well in clinical practice. The current guidelines cause my patients' families and healthcare teams to worry that that same diet, which is helping their ADHD, bipolar disorder, chronic anxiety, or early Alzheimer's, is somehow dangerous. I don't envy you your task. The nutrition literature is vast. It's heavily influenced by politics, money, and the strong personal feelings we all have about food. However, I sincerely hope that you will stay intellectually curious, ask fresh questions, challenge assumptions, and acknowledge the limitations of the science rather than presenting it as settled, to allow clinicians and patients the freedom to discover what works best for them within their dietary pattern of choice. Thank you for your work and best of luck. We're all counting on you.
Commenter 44.
My name is Dr. Kate Shanahan. I'm a family physician from Florida. I'm here on behalf of myself. I wrote a book about 10 years ago about how families used to raise healthy children using the resources they had available to them in their environment, whole foods, basically. The book is called Deep Nutrition: Why Your Genes Need Traditional Food. And what it does is basically take a look at the obvious changes that have happened in the past 100 years to our food supply, the way we feed ourselves, that amount essentially to a massive nutritional and dietary experiment involving hundreds of millions of participants in this country alone over hundreds of years. And the obvious is that 100 years ago, people were self-sufficient in their food to a degree that we can't even really comprehend anymore, because people hunted, people fished, people had a garden whenever that was possible. People raised their own animals. They cared about the health of the animals that they raised. They cared about the soil. It was their job to bring up healthy children, because if they didn't do it, the government wasn't going to help them out. And so what has changed over the past 100 years is that now we have very few people who have any of those skills. We have lost the skills of gardening, of farming, of cooking, of knowing even how to combine flavors in a tasty way. We've lost the knowledge of culinary skills that used to be considered essential, making stock, using the whole animal or the whole plant. We've lost so much. We've lost knowledge, we've lost time, we've lost health. Over the past 100 years, so much has changed. And one of the most important changes, I think that the fact that so many things have changed actually is important to point out, because it is very confusing to understand what we really should be doing given the degree of alteration of our food supply. But what I want to share with you is that the most important change, in my opinion, as a Cornell-trained biochemist, is that we now eat 80% of our fat calories from refined, bleached, deodorized vegetable oils, and only 20% of our fat calories come from any kind of whole foods. These vegetable oils include soy, corn, and canola, And they are nobody's friend. I've heard nobody up here talking about how we need refined, bleached, deodorized vegetable oils. They are unhealthy because they deteriorate in our body in ways that promote inflammation, that promote DNA damage, mitochondrial damage, and are associated, that kind of damage is associated with every disease.
Thank you for your comments.
Thank you.
58 is not present, so we'll move on. Commenter 59.
Thank you. I'm Jamie Bales, and I'm a pediatrician and pediatric endocrinologist from Huntington, West Virginia. And I've been in practice for 25 years, and I've referred a lot of patients get referred to me because of overweight and obesity in children. In the first 5 years of my practice, I've followed the American Academy of Pediatrics guidelines and I placed all these children on low-fat diets, encouraging more fruits and vegetables, encouraging whole grains, and more exercise. And one of our pediatric residents did a research project, and he looked at 75 patients that I had placed on these low-fat diets and referred them all to dietitians. And what he found was stunning to me. He found that none of them lost weight, not one. And they all gained weight at the same rate, and some gained weight even faster. Well, this was confusing. I thought I was doing a pretty good job. And so as a good pediatrician, I was sure that these patients just weren't following my guidelines. And so after some reflection, though, and actually doing some research, I came to a different conclusion. Perhaps that fat wasn't the problem. And physiologically, it makes sense. Carbohydrates and sugar stimulate insulin secretion, and insulin is a hormone that stimulates fat storage. So 20 years ago, I started a different approach. And I was skeptical. I didn't know if it would work, but the first patient I saw was a 10-year-old girl, and she lost 14 pounds in 2 months, 24 pounds in 4 months, and she continued to lose weight until she reached her ideal weight, a total of 50 pounds. I have since gone on to see hundreds and hundreds of growing children lose life-changing amounts of weight by restricting sugar and carbohydrate intake. To a T, the parents tell me the kids feel better. They have more energy. They're less hungry, and they end up actually eating less. I have seen several growing kids lose over 100 pounds. Talk about life-changing and self-esteem improvement. Now, about a year ago this September, I had a 16-year-old patient referred to me. He was newly diagnosed with type 2 diabetes. He was 5'2", weighed 265 pounds. His hemoglobin A1C was 11.9. He was autistic, mentally challenged, and his entire family was fairly low IQ. In 10 minutes, I was able to teach his family what foods to eat and what foods to avoid. In 4 months, his hemoglobin A1C came down to 5.4 without medication. In 12 months, he lost 102 pounds, and he's maintained his weight loss to this day. Now, I know these dietary guidelines are not geared for weight loss, but if we take these guidelines and we turn them upside down and we increase our fat and cut out our carbohydrate intake, we see tremendous weight loss. So our goal should be to prevent obesity, and it starts with a more balanced approach. Thank you.
Hello, I am Christine Najjar. I'm a nutritional medicine physician at Pounds Transformation in West Hartford, Connecticut. I have my training in internal medicine, primary care, a bachelor's in biochemistry, and a master's in human nutrition. And I want to thank the committee for taking on the daunting task of sifting through the ever-expanding body of nutritional literature. But I am here today to bring to your attention a substantial class of Americans that are not currently being evaluated. These are Americans with hyperinsulinemia. The hyperinsulinemia syndrome is extremely broad and includes endpoints such as obesity, cardiovascular disease, type 2 diabetes, liver disease, certain cancers, polycystic ovarian syndrome, and Alzheimer's disease. Dare I suggest that this is one of the primary drivers of the current American healthcare crisis. Now, prevalence for hyperinsulinemia will not be found accurately in the literature because it's not routinely screened for in primary care. Most clinicians have never even heard of a Kraft assay. This test can diagnose type 2 diabetes decades earlier than our current diagnostic standards. CDC estimates upwards of 100 million Americans are suffering. Now, clinicians who do evaluate for and diagnose hyperinsulinemia find that the treatment is quite simple with a low carbohydrate or well-formulated ketogenic diet. And I understand these guidelines are not for the prevention of disease and not treatment. However, I was wondering if the committee has put any thought into how they are going to address these new healthy Americans who have recovered from hyperinsulinemia and require adherence to a low carbohydrate lifestyle to stay healthy. Clinically, if these Americans consume any of the dietary patterns currently available in upwards of 50 to 55% of their daily calories from carbohydrates, disease will recur. So much for prevention. These Americans require a low carbohydrate dietary pattern. And with numbers like 100 million, I'm not too sure giving a blanket statement about how much starch and sugar we should all be consuming is a great idea. And to help define what low carb is, I suggest familiarizing yourself with a physiological concept called personal carbohydrate tolerance, defined by Finnick and Woli. And perhaps maybe the first step towards effective change is to step away from nutritional epidemiology and start engaging in open discussions with clinicians who are already treating and successfully preventing hyperinsulinemia. And perhaps maybe then screening for and treating for hyperinsulinemia will be incorporated into primary care, and together we can all make Americans healthy again. Thank you.
Good afternoon. My name is Eric Sodicoff. I would like to thank the members of the committee for allowing me to speak before you today and doing its important work. I'm a medical doctor, internist, obesity specialist, and sometimes a hospice in Philadelphia. I've become an advocate of low-carb diets. I traveled here because I would like the DGA committee to give serious consideration to the evidence-based supporting the utility of low-carb diets in preventing and reversing metabolic disease. During my 20 years of practice, there has been a dramatic rise in type 2 diabetes and obesity, yet the DGA has done nothing to arrest it, and I suspect it might actually be contributing to the epidemic. I practiced conventional style medicine for 15 years of my early career. I rapidly churned through patients while writing a lot of drug prescriptions, which, truth be told, didn't do anything but mask the symptoms of chronic disease. Then 5 years ago, feeling rather burnt out, and I read a startling book by two journalists that introduced me to the scientific literature supporting low-carbohydrate diet to promote human nutrition, a body of literature that is still not found in the DGA. Now, in defiance of the DGA patterns, I teach low-carb diets to my patients, in whom I see marked quantifiable improvements in multiple health factors, both objective and subjective, while using less medicine, and I simply love my job now. Roughly, 3/4 of the patients who I find on my hospital list every morning are there with preventable diseases, such as diabetic kidney infections, dental disease, cholecystitis, diverticulitis, kidney failure from diabetes and hypertension, coronary disease, arrhythmia, and most troublesome, suffocation from excess body fat, among many others. All three of the USDA HSS dietary guidelines call for 55% of fattening non-essential carbohydrates. It is crucial that we get the DGA right this time, and because its influence trickles down throughout society. Several years ago, I attended an obesity conference here in Washington, D.C. A room full of obesity specialists were in a hotel ballroom, and the speaker asked, "Who here uses the USDA MyPlate to help your patients lose weight?" The room broke out into spontaneous laughter. This is not a laughing matter. We do need to get this right. We do need to command respect from the dietary guidelines. Thank you very much.
For sharing that. My name is Tamara Husband. I'm a family physician and obesity medicine physician practicing in Lafayette, Indiana. Thank you so much for allowing me to speak to you today. I'm here to request that a low-carbohydrate diet be included as an acceptable diet in the 2020 U.S. Dietary Guidelines. I've been practicing medicine for 21 years. My family medicine practice consisted of wonderful patients, many of whom had metabolic syndrome and obesity. I managed them the way I was trained, with medicines and instructing them to follow a low-fat diet. Unfortunately, over time, many of these patients became sicker, and I found myself chasing their blood sugars and lipids and blood pressures with more and more medicines. In 2013, I began learning about low-carbohydrate diets
as a way of improving metabolic health. I was skeptical at first, but after reviewing the literature, I gradually integrated low carbohydrate into my practice. My patients started to get healthier. I had such phenomenal success that in 2016, I completely switched the focus of my practice to obesity medicine and metabolic health. In my obesity clinic, I teach my patients how to eat a low carbohydrate, moderate protein, high fat diet. For adults, we start with 50 to 75 grams of carbohydrates per day and then often reduce to 30 grams a day. For kids, we shoot for 60 grams of carbs per day. Initially, when I explain a low-carb diet to my patients, they are flabbergasted. They cannot believe that a doctor is telling them to increase their dietary fat because they have been told for their whole lives that in order to be healthy, they must eat low fat. As my patients progress through my program, learning to eat low-carb, high-fat, I'm often able to remove medications, including those for blood sugar and blood pressure. I also see their lipids improve. I have so many stories of patients who have been successful in my program. Those who've gotten off insulin, patients who've lost 100 pounds, but I'm going to close with a story about a teenager named Chad, because really, we need to change the guidelines so the kids have a healthy future. 16-year-old Chad came to my clinic with a percent body fat of 32, which is considered obese. He was a high school swimmer and worked out 2 hours per day year-round. He was frustrated because he had obesity and pre-diabetes, even though he was an athlete. Over the next 6 months, my team taught him how to reduce his carbs, eat moderate protein, and increase his dietary fat. His blood sugars improved, and so did his weight. We've got to include low carb in the dietary guidelines. It's imperative for the health of our country and especially the health of our children.